Should I share the link to Sham? I guess I have to do that, right?
Yes, I think, yeah, sure, that's better.
Okay, so the live stream is starting now.
Akshay, can you, wait, no, it's fine. Just a meeting.
Sham is here. Comedy is here.
Prashant?
And that's it. I'll make them the hosts too.
A little bit nervous.
All of us aren't here yet.
Hmm? Is Shan here? Prashant, you downloaded the latest PPT, right?
Yeah, the last
Yeah.
one, right? The last one you sent, right? The one I asked.
That's the one with the cases, right? Cases are also attached, right?
Yeah.
Wait, let me check.
And guys, don't show any answers now because it's like live streaming. So
Answers are not in the PPT.
yeah.
Hey, wait.
Okay, yeah,
The
right.
PPT has cases attached?
Yeah. It
No,
does.
Sasank, I don't have that.
Wait.
Okay, so 4 people are yet to join us, I guess.
All right. What we are doing is when we go for the second round, we just send them the question to their WhatsApp group as well. Now, in addition to showing them on the screen, I think. I'm waiting to
How are we
confirm.
going to send that?
No,
You have been added to a WhatsApp group, right?
Yeah, I'm in a WhatsApp group.
Oh, right.
you
You don't have the pictures.
No, I don't have the pictures.
Yeah. So, Sangu, can you send it to him?
just-
We have to be careful about sending the correct case.
Yeah. Prashant, I'll just send the relevant case for you.
Should I start letting them come in?
Have all of the academics people joined?
No, but it's already like 152.
Let me put. You already posted. Yes.
Diane, Aruthni, Shan, and Shan is here.
Shan shirt ತೆಗೆದಾಗತ್ತೆ T-shirt.
Shan, can you record the video on your device? I can give you like recording rights or whatever. Or I could give it before I made you the co-host. It's fine. I'll just record it on my device. Fine. Diane is here. Aruthni is here. Who's left?
Where's Aisha?
Yeah, Aisha is left. Yes. All of you all are co-hosts now. Aisha Silva, right? Please confirm. I don't want to put the wrong Aisha into the group. Is it
Yeah,
Aisha
right, it's-
Silva?
Yeah.
Yeah, okay. All right. I guess everyone is here then. Should I admit everyone?
Guys, I have a tiny question. So for the second part of the session, right, where they'll be discussing the case, so they'll be allowed to pick the case, right, like the number of the case.
Yes.
So they will be shown the case of whatever the number that they chose at the main meeting, and then they'll be put into a breakout room, and I would also go into the same breakout room, and I would know which case they chose, right, before I show it to them.
Yes.
Okay, then it's fine. And we're still at, I have to inform Akshaya 9 when the timer is on 9 minutes, right?
Yes.
Okay, fine.
Yeah.
Yeah, you can allow them. Let them in.
I'll let everyone in.
Yeah, everyone's in.
Asanga, check your WhatsApp.
Okay.
the hell is Akansha doing?
Can group leaders confirm if all of the team members have joined the meeting?
Yeah, I'm Akansha Chaudhary is not here yet.
Okay. We still have 2 minutes.
Is my name changed? Oh, shit.
It's still just your name.
Where is she? Oh, okay.
Guys, change your name to your name, batch, and the group number. Wajib and Rahul Singh. You haven't changed your names.
So bright.
Sorry as well.
And turn your cameras on, guys. There are still some people without.
Sarushi, you haven't changed your name as well.
Did we start?
We still have one person to come.
Okay.
I have messaged him.
Navya, you have to change your name as well.
Oh, yeah.
And Wajib, put the group number.
Can you guys see my screen?
Yes.
Okay, we shall begin now. NMU ISA Academic Affairs warmly welcomes all of you to Clinical and Medical Knowledge Competition 2020. So before we begin, we shall go through a few basic rules. Right, so, okay. So first things first, please change your names please change your names to name plus batch plus team number. Make sure you guys know your team numbers. Ask your leaders if you do not. Okay, and we will be conducting the first round of the competition in breakout rooms. So when I open the breakout rooms, please press this icon that you see over here. It's called Join Breakout Room. And you shall be given options. And please go to the breakout room of the correct team. We are doing a little change over here. Team 1, please pay attention. You do not have to join any breakout room. Your competition will be done in the main meeting, so you do not have to go anywhere. But rest team 2, 3, 4, and 5, please join the correct breakout rooms. Okay, so regarding the first round will contain 20 questions, which have 15 single best answers and 5 multiple choice questions. Each question has a 1-minute time limit. So once you are inside the breakout room, please turn your mics and your cameras on. But when you are inside this main meeting or when the second round is happening, please keep yourself muted so that you do not disturb other people's presentations. So within the breakout room, you are free to discuss, keep your mics on, have a proper discussion, and reach your answers. Now, regarding the first round, if the options are A, B, C, D, the answer format has to be the question number plus the option. As you guys know that only one person from each team has to give the answers in the WhatsApp group. While the first round is happening, no one else from your team will be messaging anything on that WhatsApp group except for the person you have assigned to share the answers. So please keep that in mind. Whoever is sharing the answer has to give the answer in the format, question number, and then option. And for the MCQs, the answer has to be given in the format of true or false. So if there are 5 options here, A, B, C, D, and E, the answer format has to be either true or false for each option. There will be negative marking in this MCQs. Please take note of that. For every wrong option, there will be a negative point. For every option that you skip, there will be no negative points. So if you do not know for sure about an option, you can leave it blank as it is shown on the screen. Yes, and since there is a 1-minute time limit for each question, only answers given within that time limit will be accepted. Okay, so those were the basic rules for the first round. The second round will be done after the first round, where each team will be given a case question and will be given 10 minutes to discuss. We will explain that in detail after the first round is over. So now I will be opening the breakout rooms. Please enter the correct room. Team 1, please remember you have to stay back in this room, in this main meeting. Yes. If you are unable to join, please wait patiently. I will assign you to your rooms.
Akshadi, kindly assign me in my room. I cannot find the icon to join.
What's your name?
Akanksha Group 3.
Hold on, let me look for you.
Akanksha Single.
Yeah. Okay.
Thank you.
Akshay, I also can't find the room. Can you
Yeah,
please?
hold on. Namita. Team 3, yes.
Sukirti, team 2.
Sukirti.
Helen, team 5.
So like team 3.
Aksha Prabhati. I can't find either.
Yeah, hold on. I am just going up the list and putting everyone in the correct ones. Prabhati group 4. Okay, is there anyone who's not in team 1 over here right now? Yeah. Okay, team 2. Anyone else who's left to
Akshay, Prashant, team 5.
yeah, team 5. Okay. All right, Diane.
So I'll be sharing screen now, right?
Yes.
Okay.
Akshay, can you send me to group 5?
Yes. There you go. Team 5.
All right, everything okay?
Yeah. Everybody okay, right? Team 1?
Yeah.
Yeah, okay.
So we'll be starting right now.
Okay. Wish us good luck.
Good luck.
Thank you.
Okay.
Okay.
Okay. First question.
Wait, can you guys first tell me who is going to be answering?
Myself, Shalini Javir, will be sending answers.
Okay, fine. I'll be keeping an eye on the time. All right.
Okay, guys, single best response.
Which of the following is true if extracellular calcium concentration is low? Guys, answers quickly.
D.
D, right? D for dog.
Yeah. D.
Okay.
Time's up. Next question.
Okay, how man is brought to the ER for evaluation of female child survivors and good chances of death. Ultrasound probe is used in the mid-age of metastatic anterior cardiac chamber for anatomically, which of the following chambers are closest to the
Left ventricle. B.
B, right? Sure.
Left atrium is the posterior. Posterior most. Okay. A. Yeah. Left atrium. Posterior.
A, right?
A.
Okay.
Yeah. A.
Yeah, it's A. I think so.
That's why it caused dysphagia, right?
This,
The answer has been
it's
sent
A.
to the group, so you can't change your answer now.
Okay. A.
A.
Okay, next question.
Is a volumic contraction of the left ventricle begins when cardiac valve opens and inflates.
E.
Yeah.
E?
Yeah.
E, the last one.
Yes.
Yeah.
Yeah, right? Okay.
Okay, next question.
Non-content of functional chest cancer reflects duration. Pain relief matters. There's no recent increase in severity of pain. Use treatment. Attention, tactile. Use takes less follow aspirin and water. Use pulse therapy. Anybody have an answer about this one?
I think it's E, but I'm not sure.
Yeah, man, that man.
Rupesh didn't come.
Time's up, guys. Next question.
Superior vena cava. Inferior vena cava. Superior and Hello, anatomy.
It's C, probably.
C, right?
Yeah, C.
Yeah, C.
All right, next question.
Which of the following about beta blockers is not true? Reduce angina by reducing myocardial oxygen demand, are contraindicated in heart failure, are contraindicated in chronic obstructive airway disease, reduce left ventricular hypertrophy, reduce the incidence of sudden cardiac death after myocardial infarction. So yes, E is correct, A is correct, B contraindicated in heart failure. Are you sure?
Time.
Wait. Which one is it?
C.
C?
There are calcium blockers,
Time's
right?
up, guy.
Beta ones.
Time's up. Next question.
Caucasian male neonate dies shortly after being born. Autopsy shows bicuspid aortic valve. Had he survived, the patient most likely would have been experienced ventricular arrhythmia, overwhelming infection, aortic stenosis, bicuspid aortic valve.
A. Fatal arrhythmias.
Okay, next question.
The heart rhythm suggests a particular ventricular tachycardia is almost always narrow. Complex tachycardia cannot be ventricular tachycardia. Broad complex tachycardia can occur in supraventricular tachycardia with bundled branch block. Yes, the rhythm in ventricular tachycardia is regular.
Any suggestions?
Not
I'm
sure.
putting B, right? Huh?
E.
What?
I'm not sure, but
Time is over.
Sent.
Time's up. Next question.
which of the following is not seen in hypertrophic obstructive cardiomyopathy? Asymmetrical septal hypertrophy.
Is it E, guys?
Yeah, could be.
Hello, everyone. Don't be quiet.
Trusting your marks.
E, right? Yeah.
Yeah.
It should be E.
Okay, next question.
Which of the following is not a feature of tetralogy of alcohol stenosis, particular habit of
What is the answer for this?
A?
No, it's D, right?
No. Problem.
What? It's D. Hmm?
Yeah, okay.
Overriding aorta.
Okay, next.
"45-year-old woman misunderstood her physician's instruction and took 10 pills of metoprolol instead of one tablet. She presents with some lethargy and heart rate of 44. Which of the following best treatment? Digoxin. If nothing, shall we do A?
Yeah.
Yeah, I'm doing A. Yeah.
All right, guys, next question.
You are concerned about blockage of the artery. We know in a patient, this artery typically arises from which of the following?
Which one?
D.
D.
Who said D? No, it's not D. It should be from the right one.
A, right coronary artery.
No, it
Yeah, right
arises from inferior aortic sinus.
Which one, guys? Soon.
A.
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 Next question.
Which of the following is not true about 6 sinus syndrome? Patients are typically under complete heart block is a common feature. Systemic embolism may occur. Yes, failure to increase
heart rate with exercise is a feature. Symptomatic patient should have a permanent placement. Huh?
E.
E?
I think. Because
E,
it's
I think it's not E. Sick sinus syndrome people need permanent pacemakers.
Yeah,
I think
E
it's
is
A.
correct. E is correct. A
What?
should, it should.
E.
A.
E? Which one? Okay.
Next question.
P.
An answer has already been sent to the WhatsApp group.
Okay.
All right. Last question for the single best answer.
B.
A.
Huh?
Wait, transmural infarcts are ST.
Yeah,
What is it?
ST.
Right? They are ST.
ST elevation,
Yes.
right?
So it should be
Yeah,
B.
it's B, right?
Yeah, it's
Yeah,
B.
yeah.
B. Subendothelial ones are non-ST.
Non-ST.
Hmm.
All right. The next round for multiple answers, right? So these are multiple choice questions. You already know how to give the answers. You guys ready?
Yeah.
Yeah.
Okay.
Is this a healthy heart?
No.
False.
No.
This shows a
False.
pathological semilunar valve.
No.
It's true, right? This can be caused by rheumatic fever. Yeah, it's true, right?
Yes.
Yeah.
The vegetations. This person might have had atrial thrombosis. Yes. None of the above are true. It's false, right?
False.
Yeah.
Mm.
Okay, I'm sending the answer.
Okay. Next question.
"24-year Caucasian male with a documented harsh systolic murmur, cardiac auscultation died suddenly. His father and uncle died. A gross autopsy specimen of heart. Which of the following?" Okay, guys, answers. First one.
True.
True.
Second one.
I don't know what it is.
I think.
Hey, quickly.
True. True.
Okay, next one. Sudden standing.
Sudden standing.
False.
If you don't know, it's okay. The next one, phenylnephrine infusion lying down. Okay.
Thumbs up, guys. Next question.
The cuff should be inflated to 10 millimeters above the systolic pressure detected by palpation of brachial artery. The arm must be supported so that the brachial artery is at the level of the heart. The diastolic pressure is the point at which sounds disappear. The point of muffling of cord sound is taken as the blood pressure apparatus must be placed at the level of the heart. Anyone? Okay. The point of muffling of cord sound is
time.
Yeah. I don't know the D one.
Next question, guys.
Thirty-seven-year-old woman, long-standing diastolic murmur, dies with a massive stroke. An autopsy found inside the left atrium. This patient's condition is unlikely to result in following conditions: rheumatic fever.
Can't be. Rheumatic fever is in children, right?
I don't understand this question. This patient's condition is unlikely to result in following conditions. Rheumatic fever, it can result, right? So it's false. Is it rupture of papillary muscles?
Could be. Rheumatoid arthritis could be.
Rheumatoid arthritis. That's.
Wait, this is a
Rheumatic and
multiple
rheumatoid
choice.
is difference.
Yeah.
I can't. Wait.
I think it should be D.
Time's up, guys.
This is
next will be the
multiple choice.
Multiple,
final
not single.
question. Next will be
Yeah,
the
that's why I didn't type it.
Guys, next will be the final question of this round.
Okay. Which of the following is true in a patient with myocarditis due to dengue fever? The cardiac enzymes are usually normal. A heart block may be seen. The absence of T waves changes make diagnostics unlikely. Ventricular arrhythmias may cause death.
Yes.
Myocarditis.
True.
Yes.
D
Yeah.
is true.
Echocardiography. Regional wall motion
What's
abnormalities.
this?
Yes, true, right?
What's this? Regional wall motion abnormality.
Time's up, guys. So this brings us to the conclusion of this round.
So far, you have successfully attempted all questions except 19th, which came in late. But other than that, you have received an answer for everything on time. Okay, that was it.
Scores?
Now, we'll give you a scores later, but now we'll just wait for everyone else to return.
I didn't actually understand the 19th question. For real. They have asked unlikely to be, and what are we supposed to give as in?
Unlikely. I think it's like
So
what
it's
will not
unlikely to
happen.
be rheumatic heart diseases, true or
No,
false?
unlikely is like what can't be, like what can't cause this situation, like that.
What we rule out would be the answer in that question. Like while diagnosing the patient, whatever we rule out, that it can be rheumatoid arthritis, for example. So rheumatoid arthritis would be the answer in that question because we are ruling out that because it's unlikely to cause.
So then we have to put true for rheumatoid arthritis.
Yes.
Yes.
Because according
Are
to the
you
question,
sure?
it's the right answer.
Yeah, because rheumatoid arthritis can cause this. So it's unlikely to cause like the other thing, right?
Which thing?
Like in the question is said, okay, rheumatoid arthritis
No,
can cause.
according to the
Rheumatoid and rheumatic are different, right? What we studied was rheumatic endocarditis and rheumatic diseases. Rheumatoid is
rheumatic fever and rheumatoid arthritis are two different things.
Yeah.
So it can cause rheumatic
Rheumatic
fever, but
fever is the
rheumatoid
one who causes
yes. But rheumatoid arthritis is completely different. That's an autoimmune disorder.
different, yeah.
And that too, rheumatic fever mostly occurs in the small kids, like not in the elderly age. But rheumatoid
from ages 5 to
arthritis is the
15.
main cause, we can say, for the like 30+ year patients.
But why rheumatoid arthritis? That's an autoimmune disorder.
They gave it in the question. I can't remember. Something rheumatoid
Yeah,
was
it
there.
was no, the age was mentioned, right?
No. Anyways, we have to rule out rheumatoid arthritis because that heart problem doesn't cause by rheumatoid arthritis.
That's
It's
joints,
just rheumatic
right?
fever.
Yeah.
But then in rheumatic fever, they have migratory polyarthritis, which is not rheumatoid arthritis.
Yeah. So in that question, the answer would be rheumatoid arthritis.
No, but that
that's
was
a multiple choice.
multiple
That's
choice.
One of
why
the
I was.
answer would be.
So like there could be 2
I
or
was
3 or
so
many answers correct.
Yeah, the time wasn't enough for me to even read it. Actually, at
Okay,
least we should suggest 1 point. Hi.
Yeah.
Akshay, yeah.
Team 5 has returned back to the meeting.
Okay.
Look at their faces, we'll get to know.
Hey, wait, let's go look at them.
They seem happy.
Oh, these guys.
Very nice then.
Are y'all happy?
Yeah,
About it?
especially Charunya.
Yeah,
Charunya.
I know happy, don't I? Wow, you guys are awesome. That's it.
Just look for the faces of the organizers. They look so. Oh my god.
What happened?
I can see Ayesha, Prashant, and them. Oh my god.
Yeah.
Why?
What's up?
Disappointed faces, I suppose. They were from.
I don't know. The team that I was in charge of, they managed their time well. They had one person to read the question, so that was good.
But overall, the performance. Oh.
Prashant, did you make the questions?
No.
Because there was so much arrhythmias.
Yeah.
So I was like, it should be Prashant.
I was not a part of this. I was just informed day before yesterday to be a judge.
Okay.
God. Just like.
I think team 2 has also come back now.
Academic affairs people, please join the WhatsApp call I'm about to start and mute yourselves. Mute yourselves and join the WhatsApp call I'm going to start now. Guys, these are the correct answers. Okay.
Okay. First one is right. Second one is also right.
She sent me 7 out of 50.
Shan.
For them, they have like
Okay. First of all, guys, so we took the answers. We took the answers that you gave for the SBA, not for the MCQ, and we came up with the rank for the next round. So Akshaya will announce the ranks. Akshaya.
Akshay, you're muted. I can't.
Akshay, I'm not audible.
Still can't hear.
It's someone else.
Send the picture on the group.
Prashant, can you announce the results with the marks?
guys,
Hello,
I'm going to.
am I audible?
well,
Oh, okay, yeah. Sorry.
Prashant.
Okay, guys. So according to your SBA marks, right? Team 5 scored the highest, right? Team 5 is first place. Next is Team 3, then Team 1, then Team 2, and finally Team 4, right? So it's 5, 3, 1, 2, and 4. Okay. So for the second round, Team 5 will get the first opportunity to select the question. Okay. For our case discussion, they get the first opportunity to select the question, and we are going in that order. The next opportunity will be taken by Team 3. 5, 3, 1, 2, 4. Okay.
Okay, guys, I'm going to put up the pick your cases page. There's no description of any cases. It's just numbers. But to make sure that there won't be, okay, you basically select your case. We are not going to assign any case based on any number. So Team 5, you have the first pick. Just select a number.
Wait. Oh, okay. So we are supposed to pick from these 5, right?
Yeah.
Just give me a second.
And do you see the questions?
You do not till we go to the questions.
I will go with my lucky number,
Okay.
number 4.
Okay. Team 5 selects case number 4. So Team 3. Guys, you guys know the numbers, right? Team 3, 1 to 5, 4 is taken.
Let's go with third one.
Sorry?
Third one.
Third case. Team 1.
Fifth case.
Fifth case. So there's cases 1 and 2 remaining. Okay. So Team 2, pick your case.
2.
Okay. Team 4.
Do we have a choice?
Team 4 is sorry. Okay. Now,
Shan, just repeat them and confirm. Just repeat the teams and the cases.
Yeah. So Team 5, you have selected case number 4. Team 3, you have selected case number 3. Team 1 has selected case 5. Team 2 has selected case 2. And Team 4 has selected case 1. Okay. And now Akshay, can you tell the rules? I need to prepare this PPT.
Okay, so now I will open just one breakout room, and whichever team is going first, all the team members have to enter that breakout room. Now you will be given 10 minutes, right? 10 minutes inside the breakout room to discuss the case, to decide how you're going to present your answers. There will be a few questions within the case that you guys have to present the answers for. And there will be one anatomy question. And that anatomy question has to be presented by a 2019 batch student. So it doesn't, you guys have to decide amongst yourselves who is presenting, but it's necessary that the anatomy question be answered only by a 2019 batch student. And one person has to present. After you are presenting, you will be asked a few questions from the judge's side that is separate from the questions you got in the case. And anyone can answer those questions, the questions which the judge will give. Yeah, but that is basically it. So the Shan, what is the order they are going in?
You're muted.
Shan, you're muted.
So team 4, you have the first case.
Team 5, team 5, team 5.
Okay,
No,
okay.
Team 4
5.
picked first case.
Team 5, case 4.
Okay, we'll start with case 4. So team 5, get ready. I will share the screen in a moment.
So once you're inside the breakout room, you will still have the question on the screen. So you can still look at the question while you're discussing. So I will open the room once the question has appeared on the screen. And guys, please make sure that only team 5 members are entering this breakout room.
All right.
So case 4, I'm going to present it now. Can you guys see?
Yeah.
Okay, I am opening the room so you guys can join in.
And this same case will be sent as an, okay, no.
Yeah. It will be sent to their WhatsApp group.
Okay.
Yeah, WhatsApp group.
Is anyone from team 5 unable to join? Please let me know.
Riddhi.
Huh?
Riddhi.
Oh yeah, okay, yeah, I have added you. Anyone else from team 5?
Navya.
Navya. Hold on, I'm finding your name. Yeah, there you go.
Akanksha.
Anybody else? Okay. Helen, please join the room.
You guys can discuss there.
Yes. So while team 5 presents their case, team 3 will enter the breakout room to discuss their question.
Academic affairs people, please join the call again and mute yourselves. Okay. So guys, this time you can also attempt that question or revise for your case. Use this time productively.
Okay. Team 5 has returned after their 10 minutes of discussion. So, firstly, Ishan, can you show the question on the screen again? Okay. Yes, this is Team 5's question. I will open the breakout room again. And this time, Team 3 has to enter the room. And your case question will be shown once you're inside the room. So Team 3, please enter. And Team 5.
Okay.
The
Team
first, the anatomy question has to be answered. So the 2019 batch student who is going to answer the anatomy question, can you please speak up so that I can spotlight you?
Hello? Hello? Akshaya, is the breakout rooms open?
Yeah, it's open. You can go in.
Add me, Akanksha, single group.
Just a second.
I cannot enter the breakout room.
Yeah, I added you. Okay, so the 2019 batch student from group 5, can you please speak up? The person is going to present the anatomy answer. If you're speaking, you might be muted right now. So
Hello, can you hear me?
Akanksha
Yeah.
Chaudhary. Okay, fine. I'm putting you on spotlight and you can start answering the question.
Okay. Firstly, the antibiotic therapy was usually administration intravenously first.
Wait,
and
Akanksha,
then...
wait. Judges, are you ready?
Yeah.
Okay, right. So, okay, Akanksha, you can start your answer.
Okay, the antibiotic for the appendicitis, first the antibiotic therapy was usually administered orally, firstly intravenously, then orally. And the main pathway is oral, then stomach absorption, then hepatic portal vein, then inferior vena cava, then heart, then lungs through pulmonary tongue to right heart to aorta, and aorta to abdominal aorta, and finally reach to the appendix. So this is the major circulation or the oral pathway for the appendicitis, drug for the appendicitis.
Okay, Akansha. Anything else to add?
No.
Guys, give me a second. Judges, I'm going to start a WhatsApp call. Please join that and mute yourselves here. So, Akshaya,
Yeah.
let the case discussion start now.
Okay. So who is going to be presenting the case?
It's me.
Who?
Sharunya.
Oh, okay. I will. Okay. So you have 10 minutes to present the case. All right. And your time starts now.
All right. The first, I would like to answer the question regarding what is the most likely diagnosis. Before that, I will give an introduction of this patient. He's a 60-year-old male. His name is Sunimal, and he has had a history of syphilis. Also, he has had his present clinical symptoms are mild discomfort of breathing during exercise, and also there is no during physical examination there is no acute distress of a temperature, and also his BP is a little bit high. It's 170/90, and then his heart rate is within normal ranges. And as to why, I will now answer your question, which is what is the most likely diagnosis of this patient. It is aortic regurgitation due to a Treponema pallidum infection. This usually happens when patients have go to the stage of tertiary syphilis. As to why this is, why I confirm it as aortic regurgitation is on palpation, there's a thrusting apex, which is mostly due to the left ventricular hypertrophy and the dilation of it later on when the condition worsens. And this thrusting apex is prominent as it but the precordium palpation will be different compared to the normal one, because there is a deviation of the apex due to the dilation. And also the other thing is I would like to say is there's a decrescendo early diastolic murmur as well as a mid-late diastolic murmur, which is called Austin Flint murmur. And also there are the echo features. In this case, the echo features would be the hypertrophied and dilated left ventricle. But as you can see in this case, they have mentioned that the ejection fraction is normal. So these are in the beginning stages. Now I would like to go to the next question, which is the clinical features. So you have told me to mention 5. Therefore, I'm mentioning 5, which is one is dancing carotids. The other one is demuscled sign where there's bouncing of the head. Then there's the Quincke sign on the nail file. There's the Hill sign where the lower extremity blood pressure is more than the systemic, the upper extremity BP. And also there is water hammer pulse where the it's an irregular pulse where the systolic is heard properly, and then there is a disappearance of the diastolic pulse, the beat. And the third one would be what is the management options existing for this patient. One thing I need to mention is that the water hammer pulse can be felt at the femoral artery. And also, I will go to the treatment now. The treatment would be basically to stop the increased blood pressure, and then to make sure that like there is no mostly it's usually to handle the symptoms of the caused by the left ventricular hypertrophy. Therefore, we give vasodilators, which is mostly ACEIs such as enalapril, and then beta blockers, and in some cases we can give digoxin, but it's not indicated much because of its cardiac toxicity. Also, diuretics, loop diuretics such as furosemide need to be given, and spironolactone should also be given, and also angiotensin receptor blockers. And since this is a treponema infection, since it's a bacterial infection, need to give antibiotics to eradicate the bacteria. That's my presentation.
Okay. So Sharunya, right. So I will be asking some extra questions. So for this one, your entire team, you can attempt, but one person answer, just the entire team can attempt. Okay. So your diagnosis was aortic regurgitation, right? What are some, so you said aortic regurgitation due to tertiary syphilis. What do you think are some other causes of aortic regurgitation? Some etiologies. Anyone in your team can answer. Y'all can.
Rheumatic endocarditis.
Okay. Can you give me at least, let's say, can you give me at least 4?
Rheumatic heart disease, syphilis, infective endocarditis, and aortic dissections. Aortic valve dissection, and ankylosis spondylitis, which is a chronic.
Also, there is connective tissue disorders such as Marfan syndrome.
Right. Okay. Excellent. Excellent. And one more question. So this case, they talked about an early decrescendo diastolic murmur, right? And mid to late diastolic murmur as well, which you described as the Austin Flint murmur. If this is a case of severe aortic regurgitation, would you hear anything else on auscultation? Anything else?
If it's
you hear a systolic outflow murmur. And yeah, systolic outflow murmur, and the S2 sound is reduced.
And the last question, which one do we usually prefer for aortic regurgitation? Do we only use medical management, or do we go for surgical management as well?
If it's a symptomatic one, you use surgical management where you have to replace the aortic valve either by prosthetic or bioprosthetic. It's better to use prosthetic because bioprosthetic, the aortic regurgitation can relapse. And when giving prosthetic, you have to give anti-thrombolites like warfarin or aspirin.
Okay, right. Thank you very much.
Okay, so team 3 has returned. Can the team 3's case question be shared on the screen? I will be opening the room now for team 1 to enter. So team 1, please enter the breakout room. Once that is done, team 3 can start presenting. So team 1, please join the breakout room now.
Akshaya, I can't join.
Yes?
I can't join.
Unmez, right? Hold on.
Yeah.
I can't see your name. Just 1 second. Yeah, there you go. Is anyone else here in team 1 who has not yet joined the room? Okay, so team 3, the 2019 batch student who's going to answer the anatomy question. You can start now.
Sure. The great saphenous vein is one of the largest veins of the body. It has main 6 tributaries: small saphenous, accessory saphenous, anterior femoral cutaneous, then superficial epigastric, superficial iliac circumflex, and superficial external pudendal vein. These are 6 main tributaries of great saphenous vein.
Okay, and is the person who's going to present the case ready?
Give me a second, Akshay. Sarnash, is there anything else you want to add? Is there anything else?
No, just it was asking for the tributaries, and this great saphenous vein drains into femoral vein, and that finally drains into that inferior vena cava, and it drains into the right atrium.
Okay, thank you.
Yeah.
So Akshay.
Yes, is the person who's presenting the case ready? Can you speak up?
Yeah, ready.
Yeah, all right. So you have 10 minutes to present your case and your time starts now.
The most likely diagnosis of this patient is infective endocarditis. The reason is because this patient has been having 2 weeks of fever and then chest pain, night sweats and chills, and also murmurs. So usually fever and these murmurs are, they make us suspect that this person is having infective endocarditis until it is proven otherwise. And to confirm the diagnosis, I think we should do an echocardiogram to
Wait, before that, Anything to add before you go into the diagnosis part to confirm the diagnosis? Anything else which can supplement your answer for the first question?
Also the high in white blood cells, and this person can be obviously immunocompromised because this person is a drug user.
All right.
Yeah.
All right.
To carry out to confirm the diagnosis, we can do an echocardiogram and also blood culture, and we can observe under the modified Duke criteria to observe whether there is a positive blood culture in two separate cultures. Then we can confirm the diagnosis. And third question, when it comes to management, we know this patient is a drug user. So they are immunocompromised and they have a very high mortality. So therefore, the best management option would be surgical management, and at the same time, we can give antibiotic therapy and help in controlling the addiction.
All right. Is that your final answer? Do you have to add anything else?
That is my final answer.
All right. So let me ask you a few more questions. You said that your diagnosis was infective endocarditis, right? And you said the patient is likely a drug user. Yes. What's the commonest causative agent associated with IV drug user induced infective endocarditis?
Can you please repeat again?
The commonest causative microorganism which is likely to be associated with IV drug induced infective endocarditis.
Staphylococcus aureus.
All right. One more question. Can you name a few, at least 3 or at least 4 signs and symptoms which are associated with infective endocarditis?
There can be fever, night sweats, weight loss.
You already mentioned them. I'm asking in addition.
Clubbing of fingers, splenomegaly,
Osseous nodes,
JNA lesions.
All right.
And hematuria or vasculitis.
All right. The last question. So you said this patient has to be, okay, first you said it's surgical management is necessary, and then we have to give the patient antibiotics. What route of choice do you use to give these antibiotics?
IV.
All right. Thank you.
That was team 3. Team 2 team 1 is still inside the breakout room. But I guess we can have the question up on the screen so that you guys can have a look at it before they are here to present it. Comedy. So team 1 chose case 5. Okay, so team 1 should be out of the room in a minute. So team 1 is here. I'll first open the breakout room for the next team. That is team 2. I have opened the room. Team 2 members, please join the breakout room now.
Can you please add me, Sukirti?
Yeah,
to the
just a
breakout room?
minute.
Okay.
Yeah. So Kirti, there you go. Anyone from team 2 is still here? I do not think so. Okay, so case 5 anatomy question. Is the 2019 batch student ready to answer? Please speak up, the 2019 batch student who's going to answer the anatomy question.
I will.
Yeah, okay, go ahead.
The hepatic portal vein receives blood from the spleen and gastrointestinal tract, and it transports it to the liver for filtration and processing. It is mainly formed by the union of splenic vein and superior mesenteric vein in most individuals behind the neck of pancreas at the L1 vertebral level. The main tributaries of hepatic portal vein are the splenic vein, superior mesenteric vein, the cystic vein, the paraumbilical vein, right and left gastric vein, and the superior pancreaticoduodenal vein. Now, these major veins are also further divided into some tributaries, like the splenic vein has tributaries corresponding to branches of the splenic artery, and the inferior mesenteric vein, and veins corresponding to branches of inferior mesenteric artery. The superior mesenteric vein is further split into veins corresponding to branches of superior mesenteric artery, inferior pancreaticoduodenal vein, and right gastroepiploic vein. So, yep. Thank you.
Do you have anything else to add?
No.
Okay. So who's going to be presenting case 5? Are you ready?
Yeah.
Okay. So you have 10 minutes to present and your time starts now.
Okay, team 1, our case is about a 67-year-old male who is having a history of hypertension and brought to the ETU by his wife for a collapsing for 15 seconds, like collapsing. And according to the history, no lightheadedness, nausea, diaphoresis, chest pain, palpitations or confusions, convulsions. And he's a known patient for hypertension who is using the metoprolol to control hypertension. And his vital signs are normal. And his examination findings are insignificant. And according to the ECG, we can see an AV block here. And
comparing to the previous and after QRS complex, PQR complexes, we can see that the PR intervals are regular in the previous and after complexes, and there is a prolonged interval between the third and the fourth ECG complexes. And here we diagnose it as Morbid's type 2 second degree AV block. So yeah, and the AV block as a whole is classified into first degree, second degree, and third degree AV blocks. The first degree is the depolarization wave from SA node gets delayed somewhere along the conduction pathway. So the PR interval prolongs, no miss beats. And the second degree AV block is divided into two, Morbid's type 2 phenomenon and Wencker-Bach phenomenon. In our case, the Morbid's type 2 atrial contraction without a subsequent ventricular contraction is proceeding. And then the Wencker-Bach phenomenon, progressive lengthening of the PR intervals can be seen. Then failure of conduction of an atrial beat is seen, followed by a conducted beat with a shorter PR interval than before. So from that, we diagnosed this as a Morbid's type 2 AV block, and there is a third degree heart block as well, that is called a complete heart block. Atrial contraction is normal, but no ventricular beats are conducted to the ventricles. So, and the drugs which are contraindicated in this condition, one is digoxin. Digoxin slows the heart rate and prolongs AV conduction. If in this case the AV conduction is further prolonged, the AV block is worsened. And then the next one is we can't use beta blockers in this case, because beta blockers also reduce the oxygen demand of the heart contractility, and the force of contraction. So if in this case, if beta blockers are used, the AV block is further worsened. And the special concern in this case is the patient is using metoprolol, once again a beta blocker, as a control of the hypertension. So if this drug may also predispose to the condition this patient is having.
Okay, let me ask few questions. So you told this is type 2 second degree AV block, right? So can you name some underlying causes for this heart block?
Underlying, yeah, ischemic heart diseases and fibrosing of the conduction system, like in connective tissue disorders.
Name 4, like 2, okay.
Natural aging also, and hypothyroidism, like low level of thyroid, and
electrocution. Electrocution, which causes damage to the conduction system of the heart.
Okay, I'll ask the next question. Out of the 2 types, which second degree heart block is more likely to progress to complete heart block?
Sorry, again.
More likely to
progress to a complete heart block.
Morbid's type 2 heart block can cause complete third degree heart block. And also there's another type of a block called 2-to-1 block that also causes complete heart block. Those two.
Okay, that's all. Thank you.
So that was team 4. Team 2 is still inside the breakout rooms, but Comedy, we can show the case question for team 2, which is case number 2. So you guys can have a look at this while we are still discussing. Okay, so
Can you
team,
see? Am I stuck?
yeah, hold on. So team 2 is back. I'll first add team 1 to the breakout rooms. Team 1, please join the breakout room now.
Team 4, right?
Team 4 already presented. It's team 1's time now.
Team 4 is presenting case 2.
Yes.
It's team 2.
2 is 2.
Team
2
2 is presenting case 2. Team 4 already presented.
No, team 4 is presenting case 1. They are the
Yeah.
ones who have to go to the breakout room.
It's 5, 3, 1, 2, 4.
Oh yeah, it's 4. Team 4 now. I'm so sorry. Yes, sorry. Team 4, please join the breakout room.
Aksha, can you help me?
Can you tell me your name?
Prabhadi.
Oh, sorry. I can't see your screen. Sorry.
No problem.
And Shashank.
Just a second. There you go. Is anyone else from team 4 here?
Gauri.
Can you tell me your name?
Gauri.
Oh, Gauri. Okay. Yeah. Anyone else? Okay. So Now it's case 2, and team 2 is going to be presenting it. Is the 2019 batch student ready to answer the anatomy question?
Yeah, I'm Sukirti from 2019 batch team 2. Okay, should I begin to answer?
Yes, please start.
Yeah.
Okay, the question is the boundaries of the transverse sinus. So it's quite simple. In the front, it is the transverse pericardial sinus is behind the two outflow arteries of the heart, that are pulmonary trunk and the ascending aorta, and it is located in front of the superior vena cava. And if we speak embryologically, then we could say that it is behind the arterial portion of the heart and in front of the venous portion. And we can also say that the left atrium forms the the right atrium forms the lower boundary of the transverse pericardial sinus. And to add on to the answer, we can say that during a cardiac surgery, the importance comes into that we can see the importance of the transverse pericardial sinus, because it allows the surgeon to temporarily ligate the pulmonary trunk and the aorta. And that's about it.
Anything else you'd like to add?
No.
Okay. So the person who's going to be presenting the case, are you ready?
Me. Yes.
All right. So you have 10 minutes to present your case, and your time starts now.
Okay, this patient is a 50-year-old man who already has an ischemic heart disease. So we diagnosed this with congestive heart failure because this patient already has been on IV furosemide and an ACE inhibitor. And now he is acutely ill. Why we say this is congestive heart failure? He has left and right heart failure, probably left and then right, because of JVP increased, elevated while sitting 45 degrees up, and lung has S3 heart sound, and lung has lung had bilateral peripheral edema, which suggests right heart failure, and he also has holosystolic murmur, which I think it's a mitral regurgitation, and his CVP is high, which also suggests heart failure. So in a person who has right heart failure, we anticipate having ankle edema, cold peripheries, splenomegaly, hepatomegaly, ascites, and pulmonary edema. And when it comes to left heart failure people, we would have cold peripheries, orthopnea, exertional dyspnea, and orthopnea, exertional dyspnea, And the treatment modalities we will be having for this patient. This patient is already on a IV furosemide and an ACE inhibitor. If this patient come acutely to right now here, I will be admitting that patient first, check his breathing and circulation. And if the patient has less than SpO2 less than 90%, I will administer oxygen. And then I will go for the drug administrations. The drugs that we have to administer, the inhibitors, beta blockers, spironolactone, digoxin, and warfarin. And also for this patient to be okay in the future, we will have to advise this patient for weight reduction and dietary modifications like salt reducing and reducing weight, and less oily, less fat food, and more exercises, lifestyle modifications. And we will have to give vaccine for this patient for Haemophilus influenza and streptococcus. And also the drugs that I said, furosemide, ACE inhibitors, beta blockers, spironolactone, digoxin, warfarin, and mitral regurgitation. We could go for a surgical revascularization or valve replacement. And if this patient is having further heart failure, we could go for cardiac resynchronization, and those stuff.
Okay. Ravi,
That's it?
Wait, let me check if I have said everything.
Yeah, check.
Yeah, JVP elevated edema, holistic. Yeah.
Yeah. So you said that it's congestive heart failure, right? So can you name? I mean, give some like 2 or 3 clinical signs and symptoms apart from those that are mentioned in the case. Just 2 or 3 additional ones.
Congestive heart
Patient.
failure. Splenomegaly. I mean, we did everything. Shortness of breath, edema.
Shortness of breath, dyspnea, ability to exercise.
Okay. Anything
Dysphagia. Paroxysmal nocturnal dyspnea.
Paroxysmal nocturnal
Half
dyspnea.
edema, pitting edema, swelling of
Bilateral fine
wings.
crepes.
And in
Anasarca.
extreme cases, anasarca.
Yeah, anasarca.
Okay.
And abdominal ascites.
Okay. Okay.
Pulsatile
tender pulsatile hepatomegaly. Splenomegaly.
Yeah.
Cardiac
So-
wheezing and inspiratory crackles.
Yeah.
Okay. Okay. Second question. What are the additional causes of congestive heart failure? You can just give
Wet
2 or 3
beriberi,
conditions.
thyrotoxicosis.
Okay. Anything else? Like
It could be pregnancy too. Wet beriberi, anemia, thyrotoxicosis.
any other causes of heart failure?
Pregnancy, it's physiological, but it could be pathological. Fistulas in the aorta. Yeah, AV fistulas.
Yeah, AV fistulas, yeah.
Okay, that's it. Okay, and then the last question. What can cause the chronic congestive heart failure to worsen? There are several conditions that could worsen the heart failure, congestive heart failure. Can you name like 2 or 3 max?
The congestive heart failure worsens when the decompensating mechanisms, like the compensating mechanism goes to the other way around. So, cardiomyopathy, renal failure, because that could decrease the aldosterone and all.
Just tell me 1 or 2 types of drugs which is contraindicated with the worsening of congestive heart failure. 1 or 2 drugs that can worsen the heart failure. Types of drugs, maybe.
Furos, no, not furos.
Just 1 would be fine.
Digoxin can, and maybe warfarin.
Okay.
Because okay, so in heart failure, the ACE inhibitor, beta blockers, spironolactone, they have a mortality benefit, but digoxin does not. So I think digoxin.
Okay. That's it? Okay. Okay. That's it for
Guys,
your
what do you think?
Okay. We'll wrap this part up. Thank you.
All right. And team 4 is has 1 more minute left in the breakout room. Yeah, in case one is ready. Okay, so team 4 is back, and I guess is the 2019 batch student who is going to answer this question ready?
Yes.
Okay, you can start now.
So heart is a hollow muscular organ which is situated in mediastinal cavity. One third of the upper heart is present in superior mediastinal cavity, whereas 2/3 of the heart is present in lower inferior mediastinal cavity, and within inferior it is present in middle mediastinum cavity. Then various projections are seen in heart, such as atrioventricular valve between right auricle and right ventricles is tricuspid valve, which is present at fourth intercostal space, and that two bicuspid valve is which is present between left auricle and left ventricle is also present at same level, fourth intercostal space. Moreover, there are two more valves, such as pulmonary valves and aortic valves, which are present at third intercostal space. Various other surface markings are from aorta. There are several right auricle. There is a uh, uh, superior vena cava opening is there, and inferior vena cava also opens in right auricle, which pours deoxygenated blood from whole body. And from left auricle, from left ventricle, three major aorta passes, which supplies oxygenated blood to various parts of body. That's it.
Satyam.
Thanks.
Okay. So next is going to be the case presentation. Who's going to present the case?
Is the student who is presenting the case ready?
Hello.
Group 4.
Yeah. 1 minute. Sharud is presenting.
Yeah, can you hear me?
Yes.
Who's presenting?
Sharud is presenting.
Can you
Okay.
hear?
Your voice is very faint.
Now?
Better.
Okay. So our case is about a 20-year-old man coming for a routine medical examination prior to an employment. However, he has no active medical complaints, no medical problems. He does not take medications or any drugs. However, he does tell you that 9 months ago, he experienced an episode of syncope after playing volleyball with some friends, and that he did have an episode of dehydration but did not seek medical attention. He has no family history or anything cardiovascular disease related, but it is also reported that his father died at the age of 40 for unclear reasons. And so coming to the question, the most likely diagnosis that we could come up with was HOCM, that is a hypertrophic cardiomyopathy, where the septum is the septum wall has a the septum wall is enlarged, hypertrophy, and we came to this diagnosis because according to this case, when the Valsalva maneuver is done, there was an increased intensity of a murmur, which they said that was present in this male, which is 2 to 6 early systolic murmur, left lower sternal border, and there is no clear signs of jugular venous distension or any upstrokes. His blood pressure is low and pulse rate is low, respiratory rate is normal. And from moving from a standing position to squatting, again, there is a recumbent, there's an increase in intensity of this murmur. So yeah, that's how we came to the diagnosis of HOCM with the S4 Gallop as well. And the next diagnostic step would be performing an echocardiogram on this patient. And the best therapy for this patient is giving beta blockers to make the heart more hypokinetic, or a surgical excision could be done, a septal myectomy, or else using a catheter, they could inject alcohol and irritate the fibrotic scar to decrease the obstruction. Yeah.
Okay, so Sharud, I'll be asking the questions.
Yeah.
So the first question, why does the Valsalva maneuver, or why does the person standing up, why does the intensity of the murmur increase then?
Because the end-diastolic volume increases when he is squatting or moving from a standing, moving from a standing position to a squatting position. So the gap between the mitral valve leaflets and the septum, the hypertrophied septum, reduces, which causes the murmur to increase in intensity.
Good. Next question. So it is said that HOCM, that is your diagnosis, right?
Yeah.
It is the most common cause of cardiac-related death in children or in young adults. Okay.
Okay.
What are the causes of HOCM?
It is 100% genetic. It cannot be caused by valvular diseases, HTN, or any congenital. It's just 100% genetic, 50% familial, or 50% sporadic.
Okay. And one last question. Sorry, give me a second. Can you compare the two murmurs of aortic stenosis and HOCM? When a person
aortic stenosis and
HOCM, yeah.
In aortic stenosis, you can hear ejection systolic click, which is the entire aortic stenosis is a systolic murmur, just like.
Let me make it easier for you.
Okay.
In aortic stenosis.
Yeah.
Okay. Okay, go on. Just go on. Just go on.
Yeah, aortic stenosis is a systolic murmur that has a ejection systolic click and has a ejection systolic murmur, which is crescendo decrescendo. And in aortic stenosis, there is a reversed split of the S2 sound, where the A2 sound is heard later than the pulmonary.
Okay.
However, in HOCM, there is no such.
Okay. I didn't.
Yes, click can shift to the carotid.
No, no, I didn't. Okay, I didn't give the question properly, so just disregard that question. So thank you, Sharud.
Okay, so this will conclude the first round of Clinical and Medical Knowledge Competition 2020. Can you guys just turn on your camera so that we can just take one group photo? Okay, so the next, so we will announce the results this week, and we'll also announce the timings and the date for the next next round. Also the topics for the next round. So that's it. I hope you guys had a good time and learned something. And have a great day ahead.
All right. Thank you.
Thank you.
And
You too.
guys, don't feel discouraged if you get anything wrong. I mean, the whole point is to learn something, right? So,
Yeah. And this
Bye.
is real medicine. So it will be testing everything, your anatomy knowledge all the way to the end. Okay. We want to raise the standard of our university and the international students. Okay. So you guys did really well, actually. Surprisingly, really well. And for today, the session is over.
Yeah. I think all got
see you
their
guys in the next session.
diagnosis is wrong. Right.
Can yeah. Right. Yeah. The diagnosis.
Right.
Correct.
That's an experiment.
So
I mean.
yeah. Can the leaders stay back and the others leave? Group leaders plus the NMU ISA people, please stay back. Academic Affairs Department, who's organizing this, please stay back. The others, please leave.
Okay, thank you.
Thank you.
Bye.
Bye.
Bye, guys.
Thank you, guys.
Thank you.
Akshay, can you turn off the live stream on YouTube?
Oh yeah, I will do that now.